Ladies and gentlemen, colleagues, welcome. My name's Edward Byrne, the President and Principal of King's College London, and it's a privilege and pleasure to see you all here on this rather miserable and cold London night. We've also had really major transport problems, and I think quite a few people are still struggling to get here, so don't be too concerted if they drift in during the proceedings. Now, we're gathered together for the first Peter Sowerby lecture in philosophy and medicine, a very special occasion, and I just want to make a few introductory comments. With the generous support of the Peter Sowerby Foundation, King's, which is home to, I think, arguably the largest academic health science centre in Europe, has launched Philosophy and Medicine, a joint venture between our Department of Philosophy, the Faculty of Life Sciences and Medicine, and the Florence Nightingale School of Nursing. And the aim is to bring philosophy and health and medicine close together to involve philosophers in the education of clinicians. But in addition, the second aim, equally important, is to host a range of public lectures and activities to encourage dialogue and collaboration across these disciplines, philosophy and medicine. David Aspinall, the chair of the trustees of the Peter Sowerby Foundation, trained here many years ago and said that since his training at King's and Guy's in the 50s and throughout his career, he wanted to see practitioners, clinical practitioners, better equipped to engage with such vital issues where philosophy may shine a light in the course of delivering patient care. I can attest to that in my own career as a clinical neurologist, where I encountered many problems, all with major medical ethics implications, where direct engagement of philosophy and healthcare was crucial in developing a sustainable action plan and position. I won't go into this, but some of this may come up in the discussion. Now, without further ado, I want to introduce Sherry Roosh. Sherry joined King's fairly recently to our philosophy department and has been here almost a year. She has the Sowerby Chair in Philosophy and Medicine, and she came from Berkeley, where she was Professor of Philosophy and Chair of the group in Logic and the Methodology of Science. She trained in mathematics and philosophy before doing her PhD in philosophy at Harvard. She specializes in epistemology and philosophy of science and has published many articles in scholarly journals. Some of her current work is focused on what it is to understand why something is true and the relation of this to empathy and compassion fatigue. And I could say a lot more about Sherry, but I think for the moment my role is simply to ask her to make some further introductory remarks before I introduce our first Peter Sowerby lecturer. So thank you very much.
Thank you, Principal Byrne. We're thrilled to see so many people interested in these topics. We are starting something new here with the Sowerby project, but I want to say that the groundwork for it was laid over the past decade or so by other people like M.M. McCabe and David Papineau and David Galloway in my department, and Brian Hurwitz in English, and whom you'll hear from later. They started the Center for Humanities and Health and had the Concepts of Health seminar, and began degree programs around medicine. But all of this takes place on the Strand. And what we're doing now is trying to take advantage of the fact that we're a multi-faculty university and bring the campuses together so that philosophers, for example, can talk more to people who actually do the medicine and study the medicine. And I want to thank people from the other campuses than the Strand, the Guy's and Waterloo and the Institute of Psychiatry, for working with me and being very interested in getting involved and helping me out. We've begun having events like colloquia and reading groups, and we're going to continue to do that next semester. And also next semester in May, on the 3rd and 4th, we'll have a symposium called Self-Knowledge in and Out of Illness. So mark your calendars for that. You don't have to take notes because it's all on our website, philosophyandmedicine.org. We invite you to go there. But the real reason I'm at the podium right now is to award the Sowerby Essay Prize. The topic of the competition this year was the placebo effect. We know that some drugs are no more effective than a sugar pill, and so we control for this by doing studies that are placebo-controlled. But there's now evidence that placebos can lead to objectively better outcomes than if you get no treatment at all. And this is beginning to be called the treatment effect, which is the effect of experiencing something, could be anything, as a treatment. We asked in the essay competition how this mind-over-body phenomenon is possible. Now, there are mechanisms for it that is an active area of research, empirical research today. And the author of our winning essay put this material into the context of broader thinking about the mind itself and the relationship, the age-old question of the relationship between the mind and the body. We shouldn't be entirely surprised that states of mind can have effects on the body. For example, stress prompts the body to the state of fight or flight rather than the rest and digest mode, and that affects our immune system, our digestive system, and among other things. We know this is familiar. We also shouldn't be surprised that the body has the ability to heal itself. After all, a wound heals itself spontaneously, like if you cut yourself, right? What may be surprising about placebo is the idea that a belief could make something like that happen. The main mechanisms that scientists have found for this are expectation and conditioning, and there's a lot of work on this to understand it better. But to think of it from the first-person point of view, our author assimilated the phenomenon to the growing evidence that our beliefs about what is possible affect our physical performance in ways outside of medicine, some of which we're familiar with, but they're being studied scientifically. For example, verbal encouragement actually does increase the peak performance and endurance of our muscles. We're familiar with the fact that believing something isn't possible can hold us back, and believing that it is possible can make it possible, unleashing capabilities that we didn't know we had, by increasing our effort. So, half tongue-in-cheek, our author of the winning essay suggested that we rename the placebo effect the temptato effect, after the Latin, I will try. Very interesting essay, which I suggest that you read. It will be posted on our website tonight. And without further ado, let me introduce this person, Mark Jakunski, who's a first-year medical student. The title of the essay is We Could All Use Some Placebo.
Well, it's now my privilege to introduce our lecturer tonight. Javi Carrel is Professor of Philosophy and Head of the Department at the University of Bristol, and her work focuses on the phenomenology of illness and healthcare in patients. She received her BA and MA from Tel Aviv University and her PhD from the University of Essex. In addition to her teaching within the philosophy department, Professor Carrel also teaches at the Bristol Medical School and on the intercalated BA in Medical Humanities at Bristol. So she really does work across the interface. She's the author of a book, Illness, which was shortlisted for the Wellcome Trust Book Prize, and of Life and Death in Freud and Heidegger. Her work is also featured in many, many journals. In recent years, she's led an AHRC-funded project on the concepts of health, illness, and disease. She was awarded a Leverhulme Fellowship, recently entitled The Lived Experience of Illness. Most recently, she received a Senior Investigator Award from the Wellcome Trust for a 5-year project entitled Life of Breath, alongside Professor Jane McNaughton of Durham University. It's a huge privilege to have her speak to us tonight. Thank you.
Thank you so much. Can you hear me okay? Right in the back? Okay, good. So I'm hugely honored, and thank you so much for inviting me. This is new stuff. So even my ex-students are hopefully going to see the connections to past work. I started out working on the experience of illness and becoming very interested on the question, in the question of the relation between health and the absence of health and well-being. And more recently, there we go, more recently came across this disability paradox, which I think merits some attention and some explicitly philosophical exploration. So what I'm going to do now is present the disability paradox, look at some explanations for it. Patients, is the disability paradox the result of patients misreporting their well-being, or is it the result of healthy people misimagining what ill health might be like, or some combination of the two? So I'll just go back to this slide and say something about the title of the talk. So the person in the photo is Harriet Johnson, who's a disability activist who passed away a few years ago. She suffered from a congenital, I don't know, spine deformation of some sort. And in one of her essays, this one was in the New York Review of Books, she talked about how people sometimes came up to her in the street. She was just sort of waiting for the light to change, and people would come up to her and say, hey, you know what? If I had to live like you, I think I'd kill myself. And that phrase really captured my imagination. So I thought I should go out and see whether there are states of health that indeed are worse than death. And as it turns out, the disability paradox really gives empirical evidence to this kind of anecdotal evidence that a lot of people talk about, which is that there is a huge discrepancy between the way in which ill health is lived by people and experienced by people and the kind of relatively decent levels of well-being they report, and between the imagination or misimaginations involved in trying to imagine what it might be like to live with a health condition or a disability by healthy people. So the explanation I'm going to suggest is that hedonic adaptation and maybe more broad, more other types of adaptation are responsible for the disability paradox. And then I'll talk a little bit about the policy and philosophical implications of this. So you're in charge of timing me. Cool. Okay. So disability paradox. Here are two articulations of it. This is a paper from 1999. Albrecht and Devliger say, why do many people with serious and persistent disabilities report that they experience a good or excellent quality of life, when to most external observers, these people seem to live an undesirable daily existence? And here's another formulation. This is Ubel from a paper in 2005. People experiencing a wide range of illnesses and disabilities often report paradoxically high levels of quality of life and mood. You might say, what is the empirical evidence for these statements? So here's some examples. A by now classic paper for Brickman et al. So when I taught it to my students, they all laughed and said, oh, this is an ancient paper dating back to 1978. By philosophy standards, this is, fresh, hot off the press. A famous study in which Brickman and collaborators analyzed 3 groups: paralyzed accident victims, lottery winners, and just normal controls. As it turns out, the paralyzed accident victims are only a little bit less happy than the people who won the lottery and had lots of money and lots of good things apparently coming their way. Boyd in 1990 study that I'll talk about a bit later on. Colostomy patients rate their health state more highly than healthy population. And this is actually a really interesting study because they looked not just at colostomy patients, but also patients who had their colostomy reversed. So I'll come back to this a bit later on. Hurst from 94, similar, looked at rheumatoid arthritis patients, asked them to score their well-being, and saw again, they scored much higher than the general public. And similarly, Ashby with breast cancer patients who gave higher values to the state of having breast cancer than those without. And there are dozens and dozens of papers looking at different disabilities and health conditions and coming to fairly consistent, fairly similar results. Summarized by Ubel, who says, across a wide range of health conditions, patients typically report greater happiness and quality of life than do healthy people when asked to imagine themselves under similar circumstances. So I'm going to refer to the healthy people asked to imagine themselves under similar circumstances as hypothetical patients. And as we will see, hypothetical patients are not very good at understanding what the health state they're asked to hypothesize about actually is. Here's another interesting study looking at hemodialysis patients. So in this study, Rees et al. Used a method of measuring well-being which is called ecological momentary assessment. In this method, you give people Palm Pilots or a small device. It beeps a couple of times a day, and they're asked to just respond immediately without stopping to reflect or think about their health state. How happy are you on a scale of 1 to 7? Put in a number. And the idea is that this method overcomes some of the biasing or changing of the results, which happens when you ask people to stop and reflect on how well they're doing. Because what happens when you're measuring well-being in general is a notoriously difficult, complicated, uncomfortable thing to try and do, but there are different ways of trying to overcome some of the problems. And the problem that's being overcome here is that when you ask people to think about their health, their well-being levels, that thinking leads them to a change in their mood. So so it biases the study. So what they've done here is ask people to just punch in these numbers, and then you get the data over a week and just average the results. So the scale used here is +2 to -2. And as it turns out, they compared two groups, healthy controls and renal disease patients who had to undergo hemodialysis 4 times a week. Very uncomfortable, time-consuming, boring, and restrictive. And as it turns out, the renal patients were nearly as happy as healthy controls. So on a scale of a -2 to 2, they came out as a 0.7, whereas the healthy controls had a slightly higher 0.83. Now, when you ask the controls to estimate how happy they would be if they were undergoing hemodialysis 4 times a week, they gave a startlingly low score of -0.38. Whereas, in fact, the actual measured mood is 0.7. And similarly, when you ask patients to imagine what life without hemodialysis might be like, they said it would be great and averaged a 1.16 to this hypothetical state. Whereas, in fact, people who don't undergo hemodialysis reported a much lower level of well-being. Okay, so we can see that the misconception or the sense that a health state has a much larger effect on one's well-being is characteristic of both the healthy controls, for reasons I will discuss in a minute, but also the ill patients themselves. So they thought they would end up being much, much happier if they didn't have to undergo hemodialysis than people who didn't actually were. Okay, so I'm going to go quite quickly, and I hope this satisfies you to an extent. But now I want to go back to the question I asked earlier about health states that are worse, that deemed to be worse than death. So here's the European Quality of Life Scale, which uses a 3-level, 5-domain questionnaire involving these domains, producing 243 health states. So you've got no, medium, and high levels of say mobility issues, self-care, and so on. And that's how you generate the 243 health states. And then you go out and ask people to rate what these health states would be like, or how worthwhile a life in those health states might be. Now, when you asked, I think they asked something like 1,500 people in this particular study by Paul Dolan. 83 of these states were deemed worse than death. What do I mean by that? I mean they scored a negative value on a scale that rated from +1, which is perfect health, absolute bliss, to -1, which is the most terrible state imaginable. So if you think that 0 is death, you can see that indeed the general population deems that quite a few health states are worse than death, And that chimes with the Harriet Johnson quote I started off with. And yet, psychologist Daniel Gilbert says, people who are actually in those states rarely take their own lives. Now, one of my medical students just the other week made the point, they said, well, maybe they don't because they can't. But I think Dan Gilbert is trying to make a much more general point about the worthwhileness of having a life not being dominated to the extent we think it is by their health state. So what can we say about chronic ill health and happiness? Here are the NICE, some data from NICE guideline from 2010, looking at comorbidity of depression and anxiety with somatic health conditions. As it turns out, on that, the data in that guideline tells us that 20% of people with chronic conditions, somatic chronic conditions, are depressed, compared with 10% of the healthy population. So the overall picture tells us that there is a reduction in levels of well-being, reported happiness levels, but it's not as dramatic as one might imagine. When considering that some of these health states, like breast cancer, rheumatoid arthritis, can be very, very painful, uncomfortable, scary, debilitating, and so on. And here's a little bit more on the paradox. These are De Hayes and Van Knippenberg, who are cancer quality of life researchers. And they note that psychological symptoms do not automatically accompany physical distress. And in another paper, the assumption that the quality of life of cancer patients is worse than quality of life of the normal population is not substantiated. And you might say, this is really weird, and it is really weird, and that is why I think the people in the literature have termed this the disability paradox, because they felt that there was something genuinely perplexing about the discrepancy between the self-reported levels of well-being of people with serious health conditions and how you might view those conditions when looking from the outside, as it were. Now, there's one caveat I want to introduce at this point, and that comes from, well, is articulated by Barbara Ehrenreich in her book poignantly titled Smile or Die. So she, in that book, part of it is her relaying her experience of being diagnosed with breast cancer. And she says that one of the things that astounded her was the refusal of the people on the online fora and mailing lists and so on that she joined, so fellow breast cancer sufferers, to accept that she might have negative emotions like anger, jealousy, bitterness, fear, and so on. And they said things like, if you've come here, you've come to our forum with your negativity, we don't want it here, and you need to be positive, and if you're not positive, if you stop being positive even for 1 second, the cancer cells are going to get you. And the point here is that she was pointing to a form of social censorship, if you like. So there's a risk that some of the reports of this relatively high level of well-being might have something to do with social scripts and social censorship and the other ways in which people might feel it's unacceptable to voice negative or depressed sentiments towards one's state of well-being. So what I tried to do is to look to, in particular, to studies where the interviewees in the qualitative studies seem to be able to go beyond these social scripts of, stiff upper lip or be positive or whatever the stipulation might be. So here are some examples for, I think, a very genuine, very authentic and not socially scripted, a nice paper by David Spiegel, where he talks about one of the reasons he gives that people who suffer ill health are relatively happy is because he describes these mechanisms of acquiring mastery and relinquishing struggle. And he says, although good health is more than the absence of disease, disease does not imply the absence of happiness. And he suggests that happiness and sadness are just not poles of one dimension. So you can be unhappy about having ill health, but very happy about other things that are going well in your life. And this is corroborated by health economists, people like Helson, who talk about how happiness is an aggregate result of different life domains that are totted up separately, if you like. So I might come back to this later if I have time. So here's an example Spiegel gives in his paper. He talks about a woman who suffers from cancer who went on some special, I think it was a trip to the opera. And she says, I brought my cancer with me and put it on the seat next to me. It was there, but I had a wonderful time. And that's Spiegel's point about moving away from the sense that well-being is just this one-dimensional scale. Some explanation, Spiegel provides. He says, look, what matters to people, ill or healthy, is that they see meaning in their lives, that they have a sense of control, and that they have social connection. So things like allowing patients more control and choices about healthcare, being able to manage their life, maximizing the utilization of resources, these are the things, possibly mostly non-medical things, that largely non-medical, that make a difference to patients. Okay, so it looks like, at least in the whistle-stop tour I've just given, that objective health, so that's health as measured objectively, using techniques such as comorbidity counts or GP reports, and contrasting that with subjective health, which is health as reported by the person herself. Objective health doesn't correlate very strongly with subjective well-being. So ill people are only slightly less happy than healthy people, and there isn't a significant correlation between objective health and subjective well-being, so people's happiness. Okay, so this fellow's Epicurus, but I'll leave that for later. Okay, so how are we going to explain? So this is a disability paradox. The second task, how are we going to explain it? So previously, I suggested there were two possible explanations, that patients misreport their levels of happiness, or that healthy people misimagine what it's like to be in a particular health state. So let's look at patients misreporting. Why would patients misreport? One common mechanism that people point to is that of scale recalibration. You simply say, well, okay, I used to be able to go on hiking holidays, but now I'm in a wheelchair, so I'm going to just recalibrate and think that it's actually really lovely going to a nearby cafe and having a nice meal or something. So this is, of course, the fox from Aesop's fable, who couldn't get into the vineyard to eat the grapes and then started saying, well, I never wanted those grapes anyway. So that's an example of scale recalibration. Another reason why a patient might misreport is conversational context. Sometimes in interviews, people feel under pressure to give particular answers to particular questions, not to let down carers or relatives, to be grateful towards the healthcare professionals or something like that. Another reason might be recall bias. So you might say, okay, my health is massively reduced, therefore I ought to be less happy. So people sometimes might not remember how happy they were prior to being ill or having the accident or whatever. So people, and there's also another kind of bias which has to do with asking people to reflect or to give overall estimates of their happiness levels over long periods of time. So say, how happy have you been in the last 10 years? Well, gosh, you know, it's a complicated calculation to make. So people also make inaccurate global judgments. Why might patients misreport? Here are some reasons. They might exaggerate their reported well-being for the benefit of carers. If they're sitting there at the interview table talking to the researcher and their carer is there, they maybe say different things. They don't want to be seen as complainers. So we've got Talcott Parsons talking about the sick role and telling us that you know, we expect sick people to behave in particular ways and to conform, for example, to the expectation that they would want to get better, that they would follow the treatment and so on. They need to ensure the continuing support of family and friends. And they might feel pressure to exaggerate the benefits of a specific intervention. If you say, oh, did the 5-minute foot massage help you? Oh, yes, it made a big difference. And so when we ask people to give summary reports of extended experience, it might be that they overweigh certain features and that they're insensitive to duration. So for example, we know from Daniel Kahneman, we've got the peak end rule, so the thing that colors the most strongly people's report of a particular assessment of a particular experience is the peak, so the most intense experience in that sequence, and how it ended. And you can achieve truly remarkable results by exploiting that rule. So there's one famous experiment where people had an endoscopy, I think. Colonoscopy, okay. And had the probe left in their bodies for an additional minute, I think, including some unnecessary jiggling. But they actually assessed the longer colonoscopy to be less painful overall than the normal one, because there was the end period was one in which the instrument was immobile and was relatively painless. And then, of course, if you have an overall low mood, it might be that a normal positive peak will have a disproportionate weight. So these are some of the reasons, some of the explanations people have suggested for the patient's misreporting hypothesis. I'm not sure that this is convincing overall, and I'll come back to this later when I talk about adaptation, but here's a few reasons why it's not convincing. One, the data on scale recalibration is not unambiguous. So there's a study in which the researchers asked emphysema patients and healthy controls to rate how rubbish different states are. For example, the state of having lung disease, the state of losing a job, and so on. And when you look at what emphysema patients are saying, their rankings are very similar to those of the healthy people, with the exception of lung disease. So they rated solely the condition of having a lung disease higher than control. So that means that they haven't recalibrated, that they're not just naively shifting their entire scale, but that they're sensitive to the experience itself, and maybe they know something about having a lung disease that the healthy people don't. It ignores adaptation, which is a very strong, powerful mechanism about which I'll say more in a minute, but the explanation that patients are simply misreporting ignores the fact that they may have simply adapted to their health condition. And there's another German study that shows that in support of this idea that patients adapt, which shows that able-bodied people are willing to pay a lot more to avoid disability than disabled are willing to pay to become able-bodied, which means that they simply don't rate able-bodiedness as highly as other people. You might say, okay, but look, surely those who are badly off are simply deceiving themselves into being less unhappy. So is it the case that what we're... Oops, is this still working? Yep. Is it the case that all we're really seeing here in this disability paradox is self-deception? Patients are self-deceiving themselves. You might say, well, if you suggest that that is the case, then maybe we need to think that we all self-deceive in that sense. If we cope well with the things that make us miserable, wouldn't that be just another instantiation of this self-deception objection? You might also say, well, levels of happiness are much higher than predicted also in other cases of adversity. So if you look at people undergoing other adverse traumatic experiences, divorce, losing a family member, accidents, or even just relocating to a new country, things that really destabilize people, we can see that people in those states are also happier than predicted. And then ultimately, if we accept the claim about self-deception, what we're actually doing is rejecting the measurement itself, because what subjective well-being measures is only what an individual says about her life. And if we say, no, you're no longer, you're not the sole authority, you're playing with self-deception, you're no longer the sole authority on this, then we're simply rejecting measurement. Okay, so let's turn to the other explanation. Might it be that healthy people are misimagining what ill health might be like? And of course, this doesn't require us to completely forego the idea that patients might also be misreporting. But here are some possible explanations. So Kahneman, again, the focusing illusion. When we ask other people, healthy people, to imagine what it might be like to live with condition X, they naturally focus on condition X to the exclusion of all other things that go on in people's lives. And Gilbert says, well, look, you know, being blind isn't a full-time job. You're blind, but you also have a million other things going on in your life. So it might be that the focusing illusion is causing healthy people to misimagine. It might be, and that's something I really think is true, that people underestimate adaptation, how powerful and comprehensive adaptation might be. People have suggested that they have a generally low ability to imagine ill health and to misremember their own episodes of ill health, and that they underestimate their ability to cope. So here's the problem. So this is a more general, I think very, very disturbing psychological problem that we all have, apparently. So this is Dolan and Kahneman. And here's what they say. By and large, it appears that people adapt to changes in circumstances, but they often fail to appreciate the degree to which they will adapt to those changes. To the extent that our wants, as captured by our decisions, are based on predictions of what we will subsequently enjoy, we're often guilty of miswanting. I.e., we want things that do not make us happier, or we do not want things that would make us happier. And put your hand up if you've never done that before. So my students always bring the example of romantic relationships, thinking that you know that person will make you really happy, but in fact, yeah. Okay. So now another thing that might happen is it might be that the public or the healthy people being asked focus on the transitional loss, the loss as experienced initially during the period of diagnosis, or when the symptoms first appear, or when the disability appears. But the adapted patients ignore that transitional loss because they've adapted to it. So here's some of the problems. One question is, do healthy respondents actually understand what the ill health they are asked to rate is? So do they have full information about what a life with condition X is all about? Most questionnaires, I was actually appalled when I saw how health economists actually go out and ask people, would you rather, I don't know, lose your hearing in one ear or have rheumatoid arthritis? Rank this, you know, so it's a very well-known, well-established method for asking people to compare two different possible states they might be in and say which one they prefer. But the questionnaires don't give a lot of detail. So about rheumatoid arthritis, some of these questionnaires say something like, the condition is mildly painful and might restrict your ability to do everyday activities. So for a person who knows nothing else about rheumatoid arthritis, that is not really very much information. So it might be that people don't even understand what they're being asked about. It might be that we need to include adaptation in the factual description of the health state. So hypothetical patients should be informed of the effects of adaptation and should be regarded as simply mistaken if they refuse to accept that adaptation exists. Or as Menzel writes, the adapted patient is in a privileged position. So here's a nice quote from Dan Hausman, who wrote a very, very good book called Valuing Health. And he says this about health economists. He says, asked a hard question, economists substitute polling for probing, supposing that those surveyed have figured out how to answer the questions that the health economist is unwilling or unable to answer. So on this view, on this critical view, the information we have from healthy people is simply not reflective of their true opinions because they simply do not have enough information. So often it's been described that these health economics questionnaires give people two unfamiliar alternatives. Do you prefer, you know, the loss of a finger or I don't know, reduced sight in one eye. People just don't know how to address this. Also, you might say, patients' misreporting has been studied in depth, and there is remarkably consistent data on how happy or unhappy people are with particular health conditions, as I showed in the beginning. And if we look at adaptation, it explains both why patients might report good quality of life, because they're post-adaptation, and also why healthy people misimagine what a health state might be like, because they don't take adaptation into account. So for these reasons, I think we should support the second explanation, which is that healthy people simply misimagine, and that's what gives rise to the disability paradox. Okay, should I quickly say something about adaptation? Okay, so what is this process of adaptation? Just very briefly. It's a process that reduces the effects of a constant or repeated stimulus. So Sherry and I were just talking about toys. So we say, okay, it's Christmas, we all want to get our children or children in our family the best possible, the most exciting toy. But even the best possible or most exciting toy will be the victim of this hedonic adaptation. And we all know how this amazing new toy gets, you know, after a few days, discarded into a corner, never to be touched again, much to the chagrin of the adults who spent £80 on it. So that's an example of hedonic adaptation. It's the same with, you know, new cars, bigger houses, higher income, all of these things. So people often trade off an increased commute time for a bigger house. And that's apparently one of the worst things you could do if you're interested in your own well-being, because the one thing that is not subject to adaptation is a long commute that continues to irritate people indefinitely. Whereas the larger house with a 2 or 3 or 4 or 5 bedrooms you do undergo adaptation with respect to the house. So you lose out effectively. Okay, so what does hedonic adaptation look like? Well, it looks like it causes a temporary shift in happiness levels, upwards and downwards. So if you get married, you'll have an increase of your happiness levels for about 2 years. If you win the lottery, for less than 1 year. And we know that these mechanisms of the hedonic treadmill, so people's aspirations go up as they rise, as they get sort of higher salaries or whatever, and that their social comparisons continue to be, so you move to a better neighborhood with the bigger houses, but suddenly all your neighbors around you, they all have nice big houses as well. So you don't end up experiencing pleasure at the bigger, nicer house. Okay, so what are elements of adaptation when we think about ill health? Some of them are negative ones. So it might be that people deny what a functional health state might be like. So they say, I'm doing absolutely fine, because they've completely forgotten what they could have done or would have done or had done previously to the illness. It might be that they lower their expectations and they say, well, you know, I was told that I'll be dead in 10 months, and look, here I am 3 years down the line. I'm very, very pleased about that. And they might completely lose recognition of what full health might afford them. There are some positive elements of adaptation, so skill enhancement. People get better at doing daily routine things as they learn to live better with their disability or health condition. They adjust their activities. They adjust their goals. They have an altered conception of health, so they might define health as something like a capacity to adapt positively to problems of life. And this one I wasn't so sure if it's positive or negative, but people also point to this heightened stoicism as another element of adaptation. So just quickly to finish off, here's a quote from a quadriplegic who says, I can live life to the fullest even if I have no physical ability. I can live life to the fullest because where I'm living, life is from within. And Ubel again, who says the following, he says, a preponderance of evidence suggests that many patients with chronic illness and disability are able to emotionally adapt to their circumstances and experience relatively high levels of mood and quality of life. Even when patients do not fully adapt to their illnesses, they frequently report higher levels of well-being than what is imagined by healthy people under similar circumstances. And here are some mechanisms. So, pardon me, Jonathan Haidt tells us that people underestimate their ability to cope, and Gilbert says very disturbing things about how bad we are to remember what it was like when we were ill and how terrible we are in imagining what it would be like to live in any kind of counterfactual situation. Post-traumatic growth is also driven by data telling us that people who suffered severe stress recover more quickly when they suffer adversity again. That stress makes good relationships better. It doesn't improve the rubbish ones. And that the trauma changes the priorities and shifts the emphasis towards the present. And there is so much more I would have loved to say about this, but I think the clock is ticking, so I put some reading suggestions, and I'm happy to email PDFs and stuff to people afterwards, because I think this last point, the emphasis towards the present, we've got really lovely literature in Stoic and Epicurean writing from thousands of years ago that is really very, very relevant to this point. But here's a really nice quote that Spiegel, from Spiegel, when he's asked to explain what it is that made people with cancer have such a good level of well-being. He said, they trivialized the trivial in their life, turned down unwanted obligations, and concentrated on what matters given their dwindling resources. One of the things that mattered was the other women in their support groups. They found new meaning by using their experience of illness to help others going through the same dilemma, and came to feel like experts in living rather than victims of cancer. And I think this is really key if there's any health professionals here. This is really key for thinking about how to give people back the sense of meaning, sense of control over their life, and the sense of value, making somebody feel like an expert in living. It's quite valuable. Okay, so here's the colostomy example I promised you before. Here's one reason I think we can think about illness as a transformative experience. So this is an idea taken from the philosopher Laurie Paul, who suggests that some experiences are so transformative, so radical, that we are simply different people, if you like, or we have radically different preferences when we go through the experience, so that we cannot really imagine prior to the experience what our preferences and goals and values might be. So here's asking community members, just normal people, how they would value life with a colostomy. And as you can see, they give it a relatively low score of 0.63, and they're willing to trade off 44 out of 120 months, quite a lot of time, in order to avoid having a colostomy. Here's the colostomy patients. They're saying, look, it's actually not that bad. They give it a rating of 0.84 and are willing to trade off a much lower number of months if you compare it to the other ones. But look at the people with the reverse colostomy. This is the thing that I thought was really interesting. Their values are almost identical to the values of people who've never had a colostomy. So people with reverse colostomy seem to forget that whilst they had the colostomy, they probably would have valued it as not too bad, 0.84 out of 1. And it might lead us to suggest that colostomy and its reversal are simply these kinds of transformative experiences, that there's this discontinuity between patient and ex-patient. So what do people not adapt to? I just thought you might want to know. Noise, progressive disease, loss of a spouse of a child, and strangely enough, cosmetic surgery. So apparently, if you have a rhinoplasty, if you have a nose job, the joy will continue to be with you for the rest of your life. So something I never knew. Okay, so I think the implications of this are different depending on which explanation is right. If we say that patients are misreporting, if we say that healthy people are misimagining. First of all, both groups are guilty, if you like, of overestimating health, as we've seen in the hemodialysis example. If we accept that patients are misreporting, we're being paternalistic. if we reject that patients are misreporting, we almost threaten to make medicine not exactly redundant, but to say, well, look, you're perfectly happy with the colostomy. Why should we put so much resource into trying to reverse colostomies or make people not need them in the first place? Or we might want to say that happiness is not the direct or relative or ultimate goal of medicine. That's another thought I was sort of toying with. Okay, so to conclude, can we rely on this empirical data? I think the empirical data really supports the hedonic adaptation view. I think that even small differences in levels of well-being are important. So we've seen small differences, small reduction in the level of well-being, and it might be that even that small reduction is worth addressing. We might say that happiness simply isn't a rational or exclusive goal of medicine, in the same way that we don't send our children to school exclusively to make them happy, right? We send them to school for lots of other very valid reasons. So just last thought. This is Eric Angner, who's a health economist in the US. What are the important bits, even if people adapt? There are really crucial places where particular interventions will make a huge difference. And as he says, insofar as a medical condition impacts well-being at all, he's writing about chronic conditions, it does so for a relatively short period of time after diagnosis or symptom appearance. So the place where you want to catch people, and I'm sure Brian will have a lot to say about this, is at that time when the symptoms appear, when the diagnosis is given, not 15 months down the line when they've already adapted. Okay, sorry, I've gone over. Wanted to cover quite a bit of ground, but thank you. So this is the new edition of my book, Illness, and these are just some papers that, as I said, I'm happy to send PDFs and so on to people who are interested. Thank you very much.
Thank you very much, Professor Carell, for a wonderful talk. I'd now like to invite Professor Brian Hurwitz, one of our King's colleagues, to be a commentator. Professor Hurwitz is a distinguished general practitioner, an active family doctor in central London in the past. He has been the head of the Department of Primary Care and General Practice at Imperial College, and is now at King's as Professor of Medicine and Arts, and he directs the Centre for the Humanities and Health, which is a Wellcome Trust-funded centre. He's a perfect person to discuss the interactions between philosophy and medicine. Thank you.
Well, we've heard a wonderful lecture tonight, very rich in all sorts of ways. And the thing that strikes me about it is that within this richness, there's been a very clear formulation and a very well-informed delineation of a problem that's emerged from a matrix of health studies. You ask key questions and confront the potential deceptiveness of empirical work and the difficulty of gaining a coherent view of contradictory findings or findings that don't quite add up. I'm very struck by the scenarios that you mentioned at the very beginning, the hypotheticals, the counterfactuals, the potential role of imagination in answering what seem to be quite straightforward questions. Scenario setting has a strong influence on how people respond to questions that they're asked. But your talk clearly highlights the value of getting behind appearances, the importance of which is stressed in Mark Sainsbury's well-known definition of paradox as, quote, an apparently unacceptable conclusion derived by apparently acceptable reasoning from apparently acceptable premises. For me, your talk prompts a return to fundamentals. What is well-being? What is ill health? What kind of a concept is health? Is it a unified entity or process, which many studies here assume? Does it possess a clear referent, one that has objective as well as subjective aspects? If so, how, if at all, are subjective and objective aspects correlated? Or is health, rather than an entity or variable, really a meta-concept, a way of invoking contrasts, which, like the surgeon-philosopher René Lerich's definition of health as, quote, life lived in the silence of the organs, unquote, embodies an inherently relative idea. Should that niggle have gone away by now? Did those twinges I felt this morning mean anything? How silent is silent when we're talking about the silence of the organs? But if health does have a referent, what's involved in understanding it becomes in part getting to know something of this referent. And that's what I take it this talk tonight has been about. According to the WHO, there is a referent, and it's a very complex one, namely, and I quote, a state of complete physical, mental, and social well-being, not merely the absence of infirmity, unquote. But as Francis Allen comments in his Saving Normal, his critique of DSM-5, who among us would dare to claim health if it requires meeting this impossibly high standard? In the WHO definition, how complete is complete? And who is to define complete within what sort of a framework? And what sort of account does this framework take of what Javi has termed elsewhere well-being within illness? Why in the WHO definition is there no reference to the cultural dimensions of health? Self-rated health consistently indicates that cultural factors bear strongly on whether we state that we feel healthy. With loneliness, unemployment, bereavement, incontinence, hearing loss, as well as noise, consistently predicting low ratings. And actually those are conditions that by and large don't show adaptation. Neither does chronic, severe, progressive neurological disease of the form of MS. There are quite a few conditions in which we don't see hedonic adaptation. And so that would be an important component of analysing this further. This should lead us to ponder the psychology of claims to health. What do we mean about the psychology? What do we know about the psychology of these self-ratings and the opportunities that they offer for self-deception, as Javi mentioned, duplicity, truth reversal? Does self-assessment of health involve rating elements of happiness and contentment that are influenced by upbringing, past achievements, and sense of fulfillment? How much of the here and now is involved in assessments of health? And how much do we take into account our biographies and the foreseeable future? And there's been quite a lot of work, actually, on hedonic adaptation in the case of premium bond winners. Many biographies of premium bond winners showing how incredibly miserable and unhappy they become relatively rapidly, quickly after winning the jackpot. Some studies have looked at such questions, and they've noticed, for example, different degrees of futurity informing health assessments and differences by socioeconomic class. Those who've had a stroke frequently can experience their health as worsening, when from an objective point of view, I mean biologically and in terms of lowered mortality, health is actually improving. This is because their insight into the potentially long period of recovery and the degree of morbidity that they're likely to be left with follows the trajectory of recovery, but it also precipitates morbid thoughts, feelings of loss, and depression. In making such assessments, do people weigh separately the mental, emotional, physical, and functional dimensions of their lives, or do they fuse them together and then come up with some objective score? In other words, I think that part of the phenomenology of answering the question is not very well characterized. To complicate things further, it's not only that subjective measures of health do not always correlate with disease, but actually objective measures of health do not always reflect disease either. For example, a matched cohort study of 90% of all the type 2 diabetics in Sweden, that's 400,000 people, with 2 million matched controls, with 4.5 years of follow-up, published this month in the New England Journal of Medicine, shows that patients aged 65 to 74 without signs of renal disease, with diabetes, well-controlled diabetes, have an all-cause mortality lower than the non-diabetic controls. And similarly, mortality is lower too in patients over the age of 74 with an HbA1c below 7.9%. So we have a situation in which we can find evidence where objective health does not correlate well with disease. And even where there is evidence of correlation between subjective health ratings and objective markers of ill health, such as in the NAIN-3 data set, data from the third US Health and Nutrition Survey, which looked at 14 biomarkers, there's significant variation in biological risk and social class, so that within the same self-rated health category, respondents from higher socioeconomic classes have greater objective health for the same self-rated score than people of lower classes in the respondents. So what that's saying is that it's not just a matter of what is your rating, it's also partly a matter of where do you come from, what is your class, what is your cultural group. But you really have opened up an important conceptual set of questions in relationship to empirical studies tonight in a way that's all too rare in medicine, and we thank you for it, Javi. And I very much look forward to the discussion. Thank you.
Take a seat. And now is the time to bring in the audience. Questions, comments, interesting dialogue. Introduce yourself. We have microphones. Who would like to begin? Yes.
Thank you. To some extent, it overlaps with what Brian had said about the definition, but I'm curious about the term disability, really, and you covered quite a wide range of conditions, including cancer. And I'm just wondering to what extent the studies you looked at, whether people thought, given the disability they had, that their lives were threatened in any way, or whether that was looked at in the research papers that you presented. And I'm thinking particularly, because you touched on cancer, and whether those groups of patients were felt their lives being threatened had any impact on how they viewed the quality of life.
Thanks very much. None of the studies I quoted looked at this element that you're raising. So there isn't evidence to show that it did or didn't impact. I think the cancer studies are particularly surprising because you would expect that this uncertainty about prognosis to be very impactful on someone's well-being. So it's quite surprising, as De Hazen van Knipperg note, it's quite surprising that it doesn't. It doesn't seem to have the impact that you would anticipate it has. But you're right, the cancer instances are a little bit different than other chronic conditions where the prognosis is less difficult.
I think a lot of the data that Javi was relying on is cross-sectional data rather than longitudinal, actually. And it would be very interesting to know how self-ratings change over time and whether that's related to alterations in people's lives in a wider sense, or whether it's actually narrowly related to health, care and illness episodes.
While the audience are thinking, perhaps I could ask a question. I was really fascinated by the findings as a clinician who's treated many thousands of patients with disability. I had no great surprise in my empirical way because I was always incredibly impressed by the resilience and positivity of the human spirit. As somebody who worries a little about small things, I'm not surprised either by anticipatory anxiety for illness and disability for those who haven't had it. But my question was a more practical one, that patients are so different in terms of the panoply of symptoms they experience and the degree of social and emotional support they have. And I could imagine quite interesting and valid studies. In a way, only if one restricted many of the things, some of which you mentioned, that people don't accommodate to. So recent onset of the condition, the emotions haven't stabilized, ongoing progression, for example, in motor neuron disease, where I looked after hundreds of patients with that, where manifestly the findings you described don't occur because chronic misery continues for many people. Cancer patients who have severe pain that is poorly controlled, or shortness of breath, or the malaise and lethargy that go with cancer. Patients who have very poor social support. Now, my question is, were those things excluded in most of the studies you alluded to? And if they weren't, is there a possibility that it leads to significant cohort bias? So the findings you described are clearly there, may relate only to a sub-portion of people with chronic illness in whom the key parameters are stable. In other words, their symptoms are controlled and their social situation is well supported.
Mm-hmm. No, thanks. That's a really important point, and actually links in with what you were just saying. So as far as I'm aware, there are of course symptoms that people don't adapt to, and pain is the most obvious one. But surprisingly, incontinence, which isn't life-threatening, but it's just very socially debilitating and psychologically unpleasant. And of course, the progressive symptoms, as I described in one of the last slides. So I think a lot of these studies look at chronic illness that is well controlled. And one of the models that I think partly explains the finding is this idea of the foreground-background relationship between the illness and one's sort of overall life. So this is an idea that comes from Barbara Patterson, and she says that during episodes of symptom exacerbation or disease progression, the disease comes to the foreground and then wellness is affected. But there could be long periods where it recedes to the background. So, for example, well-controlled diabetes. And it plays a very minor role, has a very small impact on well-being. So I think if we think about long-term chronic conditions, which people sometimes live with for decades, that shifting perspectives model might be useful. The studies I looked at, I think they looked at quite a wide range of diseases, but not at end stages of those diseases, where I agree with you, the findings would probably be different.
Some more questions or comments? Yes, towards the back, and then in the middle here. Pass the other microphone to the gentleman here.
Hi, I'm a social sciences student here at King's. You talked a lot, I would assume, about studies that included adults as your main subject, and I would just be very interested to know if you had looked at or come across any studies that took into account either children or young people in the same situation, and if you noticed or if there had been anything written on significant differences in results between a young person dealing with the same situation as an adult dealing with the same situation, the results that they would feed back.
No, thanks. That's super interesting. No, I haven't. I only looked at adult studies. I haven't looked at happiness in children at all, actually. But I'd have thought there might be bigger differences because, of course, as the population grows older, more and more people might have some kind of chronic ill health. So it becomes more normalized, I suppose, whereas in children, the deficits are much more acute and the social exclusion is much more difficult. So that I think there's very good grounds to think that the results would actually be quite different. So thank you for that. I remember sitting once on a cystic fibrosis clinic, which was exclusively teenagers. And one of the discussions that I was listening in on was this 15-year-old boy who had a chest infection and was desperate to go to Glastonbury and roll around in mud for 3 days, whereas his consultant thought it would be much better for him to stay in hospital and have IV antibiotics for 3 days. And the whole discussion ended up in a sort of a compromise where the doctor said, look, I can see that going to Glastonbury is really important to you, but you've got to promise that you know, as soon as it's finished, you're right back here in hospital. And it was really obvious that for that young person, being able to go to Glastonbury meant everything, as it were, in a way that maybe adults wouldn't experience something like that as acutely. Thanks.
Hi, I just had a question about the studies, and I was wondering whether or not there were subsets within the studies where you found hedonic adaptation didn't happen as much, so personal factors about people who participated or social factors where they didn't find that they adapted as well to illness or disability, or didn't readapt as well to health and wellness after some kind of incident.
Well, the short answer is no. So what these studies, what they give you at the end is they give you an aggregate score for the groups that were being studied. I can't recall an instance where these studies looked specifically at subsets of patients. But I'm sure, going back to what Brian said about, you know, social status, class, income, we know that those kinds of things might affect people's experiences very seriously. So on the scale recalibration, one thing people do say is they say, well, if you are a cancer patient and experience really severe nausea, it might be that experiencing moderate nausea would be judged by you differently to someone who's never had the severe experience. So of course there might be issues like that about interpreting the results.
Professor Hurwitz, did you have any questions or comments?
The adaptation process that comes to mind, it's entirely anecdotal, is the pain of labour, which often patients say, you know, that's it, one's enough, I'll never ever have another one because it was so bad. But actually, it's also the case anecdotally that pain seems to recede. So I think the kind of adaptation to, I mean, that's an acute thing and it lasts a particular period of time, but it can be associated with very, very nasty experiences. On the other hand, there does seem to be quite a strong adaptive response to the memory of it. But just generally, it seems to be the case that in severe disease, if deterioration is progressive and there aren't stepwise gaps between that deterioration, in other words, if it isn't episodic, you don't seem to get much adaptation to it. I think it's interesting, the noise, you don't get adaptation to noise, and I think it's one of the reasons why there is so much concern about the noise factor around airports, because people simply don't get used to it. It's a big negative on their quality of life.
Maria Rosa Antognazza.
Thank you very much, Ivy and Brian. I was wondering how specific all this is to health and ill health, because even for some of the examples you were giving, I wonder whether something similar could be run for people who are poor and people who are very wealthy and so on. There are, I don't have the statistics, but there are reports that people in poor countries are sometimes happier than other people who are in wealthier countries who have more things and so on. And even in our own experience, we may remember when we were poorer students how happier we were than now that we have more things, but maybe not the same enjoyment for certain things. So I wonder whether this is something broader, and whether this tells us something important about happiness and what happiness consists in and what are the factors contributing to happiness, maybe not so much having things, including health, but other factors.
No, thanks. That's really fantastic. I mean, the thing that your question really brings to the fore is the following problem. So when you ask people to say how happy they are now, there are enough problems with that measurement. But when you're asking people to remember how happy they were in some time in the past, then you're adding to that the additional worry that we misremember stuff. And there's pretty strong evidence that we do, that we downplay how bad past experiences were, maybe for good, biological, evolutionary reasons. So these are really kind of notoriously, difficult things to measure. Now, I think the consensus about happiness and any type of material achievement or material good is that beyond a relatively modest certain threshold, which I think Layard puts at something like $25,000 per annual income, additional increases in income give increasingly smaller and smaller increases in well-being. So there's studies that ask people how many bedrooms they have and how many microwave ovens they have and what car they have and how much property they own. And all of these things you get kind of diminishing returns, as it were. Now, the reason I got interested in health in particular was because you think, okay, maybe how many microwave ovens you have in your house doesn't really impact on happiness at all. But your own health surely might be such a key thing for somebody's well-being. It's taken to be a necessary component of the good life, for example. So I think you're really hitting on a very interesting question, which is why and how is health different to these other kinds of measurements and lack of correlations that have been pointed out in the more general literature on happiness?
Yes, we've got 2 or 3 questions here. Maybe there and then just behind you.
Hey, you were saying about the fact that the effect reverses when the condition reverses.
About colostomy?
Yeah.
Mm-hmm.
And I was wondering if maybe that could suggest another reading of it, that it's not to do with understanding ill health and understanding the way you can adapt, but it's actually to do with being in that state, that might threaten the conclusion that it's adaptation, or maybe that might just suggest another subtlety of it, that it's to do with being in the state, because when you're not in the state you don't experience the effect anymore. Does that make sense?
Okay, why would why would the people whose colostomies have been reversed forget? So you're saying they're just not in that state anymore, so they, in a way, all their knowledge, so the knowledge is only
I'm saying they seem to have a knowledge of how you can adapt, and yet they still don't, they still estimate in line with the people who have no knowledge rather than the people who are experiencing it.
Yeah.
So that seems odd. You'd expect them to have the same estimations as the people who were experiencing it, wouldn't you? But
yeah.
So weren't statistics that they experienced that their estimations were the same as the people who
never had
a
colostomy? Yeah. So that was a surprising thing. That was the thing about transformative experiences, where one way of thinking about this is saying it's as if they never had a colostomy. So they are different people. They're almost different individuals to who they were when they had the colostomy. And similarly, the colostomy people are different people to who they were prior to having the colostomy. At least that's what, that's one way of interpreting the data. Is that what you were pointing to?
I was going to suggest that another way to read it was that it's not, that maybe they are, sorry, that makes sense. Sorry, I'll follow it up.
One of the things that paper doesn't do is say how long people who had the colostomy reversed had the colostomy for. And some colostomies can be reversed very quickly. And so the experience would be not necessarily as impactful as if you had it for years. A lot of colostomies these days are reversed rapidly, but I don't know. The data wasn't in the paper as far as I recall.
Okay.
Just 2 rows back.
I wanted to comment on the way in which the hypothetical patients were asked about, would you, if you were to suffer this disability, would you rather have this or this? I feel like something that life-changing was asked in a way that kind of resembled the childish game of like, would you rather? And I found that it doesn't really do justice to what you're actually asking. Are there any ways, or do you think, in your opinion, there's a way that you could potentially ask that question in a way that might give more, maybe not more reliable, but more insightful, more informed responses? Like, is there any way that that hypothetical patient could live a life in the day of that person who maybe has adapted, and then therefore give a response that is maybe more informed? Thank you.
Yeah. No, thanks. That's absolutely brilliant. I think what health economists are doing is just bizarre. I mean, from what I've read, the methodologies used to evaluate health states are very ill-suited to that particular purpose for the reasons that you raise. So could there be better ways of doing it? Of course, you could use testimonials from patients who are living with a condition. You could have focus groups where people would have an opportunity to discuss the different aspects of what having a condition might be like, and then make a more informed, give them more information, make a more informed decision. You could interview people with a condition. You can interview health professionals who have worked for decades treating people with particular conditions. There are lots and lots and lots of ways of getting more accurate information than asking people to compare two health states, to evaluate and say which one they would prefer. But there's also this other method of time trade-off, which is asking people how many months or years they would be willing to sacrifice in order to avoid a particular health state or a disability. But again, I think it's subject to the same kinds of errors of the type that Dan Hausman has identified.
Well, I'm sure we'd all agree that the first Peter Sowerby lecture in philosophy and medicine has set an incredibly high standard for future years. I'd now like to invite Professor Sherry Rouche to come and make some final comments and thank the speakers.
Thank you both. I wanted to mention before we leave that what our next event is, which is in January, the 28th of January. A professor at UCL is going to be talking about linking mechanisms and inferential networks in medicine. So I hope you'll all come. It's on this campus in Hodgkin Building. The other thing is there's a reception afterwards with a lot of food and drink, so you need to help us consume it all since it's there. And finally, let's thank our speakers again and thank the audience as well.